I'd like to introduce our next speaker, Dr. Bryan Campbell. I joke with Dr. Campbell and the highly esteemed Dr. Campbell. Know him very well. He was born and raised in Idaho, where he participated in the WWAMI program and graduated from the University of Washington School of Medicine in 1980. After a flexible internship at Virginia Mason Hospital in Seattle, he completed his family medicine residency at McCady Hospital here in Ogden in 1983, whereupon he joined the faculty of the residency program. He has been a member of the faculty since that time in one way or another, and has been involved in the medical education, residency education of many of the residents that have come through the program, and I know he's highly esteemed from the residents' point of view. He will be speaking to us today about clinical quality improvement, and we welcome him.
Well, good morning. We should have a lot of fun together over the next half hour. And as we do this, we will have a little bit of interaction together. So the first question to establish the ground rules are, all of those of you who are present, please raise your hand. And I see some who did not. So that's a little concerning. So first thing, of course, these days is disclosures. Well, this is true. In fact, when the Ogden Surgical Society gave me my contract, the remuneration was listed as 0. And I called Teresa Puskedra, who is our wonderful executive director, and I said, you know, with all my experience, I think I'm worth at least double that. And it took 2 weeks for them to debate that and then turn it down. So I do have an agenda today, and we will get to that. And so what we're going to do is we're going to go through some history of how we got to where we all are today. And we're going to have some fun with this, so if any of you know the answers to these, please blurt out the answers. Now, some of this is really fancy, and I have to thank Jessica. Jessica, are you in here, Jessica? Jessica's right back there shaking her head. So Jessica's part of the Ogden Surgical Society staff, and she made all the really pretty parts of this display, so thank you to Jessica. So anybody know who this guy is? 0. Okay. This actually is a very important person to all of us. This is Abraham Flexner. He was born a long time ago, and he founded a very successful private high school. And I'm actually not sure what published the American College is. I put that in there, and I have no idea what that is. But the important part is he was hired by the Carnegie Institute, and he's the guy that produced the Flexner Report in 1910. So this all came about and changed American medicine, but it started with the AMA, which was founded in 1847. And they had a goal to improve medical education. But really, for the first half century, little was accomplished. And then, around the turn of the century, they approached the Carnegie Institute. The Carnegie Institute, the Carnegie Foundation rather, was created to explore education in America and see if we could come to some consensus across different forms of education. And the first thing they tackled was medicine. So Flexner, Abraham Flexner, was hired in 1908, and he went out and personally toured and examined all the medical schools in the United States and Canada, 155 schools. And he did this in 2 years. It's really quite remarkable. The Flexner Report is still available. You can find it online. It's over 300 pages. So it really is quite the book, and there's in it some fascinating stuff, and we'll get to some quotes here in just a second. But there was one shining light in all of those 155 schools. About 13 or 14 that were kind of okay, but one really shining light. Anybody know what that shining light was? I think I heard it. Say it louder. Johns Hopkins. Okay, which still exists. So it was the shining light then. It is still a shining light now. So between looking at Johns Hopkins as an example and the German medical schools, particularly with France a close second, Flexner created a report, and he said, I want it to be a lot better. And I want you to think about what he actually did. So here was the process. He was given an assignment. He established background data by looking around, exploring what was available in all of the schools. And then he came up with a plan. This Henry Pritchett is the head of the Carnegie Foundation, and this is part of the introduction to the Flexner Report. And we'll read a little part of this. Meanwhile, the requirements of medical education have enormously increased. This is 1910. Okay? The fundamental sciences upon which medicine depends have greatly expanded. 1910. Okay, so I want you to keep that in mind. I took one little page copy. This is Utah. And I want you to go to the bottom line. Utah at this point actually came out pretty good. We had a one-year school. The teachers were actually quite good. And he said at the bottom, it is to be hoped that whenever clinical instruction is started in Salt Lake, clinical instruction then would be the second half of medical education. So what was taking place in Utah at that time was basic science. It is to be hoped that whenever clinical instruction is started, it may be only for the purpose of completing the half course, in other words, expanding that course. In that event, Utah may never know the proprietary medical school. So a lot of the schools in the country were really just profit-generating experiences for the physicians. In fact, in many of them, you didn't even have to have a high school diploma, and you had less than 2 semesters of education where you were released on the world. So when you went to see an MD or a DO in the United States, anything might happen. You certainly couldn't depend on the quality. So Flexner tried to create something different. And what did he do? He again made these baselines. He decided that what we had to base American medicine on was the scientific principles already available. And so he suggested that this happen. The result was that more than half the schools in the country closed. The independent schools went out of business or merged so that they all ended up with a university backing and a teaching hospital available to them. And the result was us. Okay, so the purpose was to cram into somebody's head as much possible information as you could get, and it created these heroes. For those of you old enough to remember Mighty Mouse, do you remember what his theme song was? Here I come to save the day. Yesterday we heard in our wonderful noon conference, we heard a lot about changes and available systems in other countries. And that sometimes when you look at American medicine and the results, we're not as good as other countries. There's one thing in which America way exceeds everybody else, and that is rescue medicine. And here we come to save the day. It also created in this craft building of medicine independent, hard-to-herd cats that are sure that what I do is right regardless of what you think. Right? Okay, so that's us. That's us here today. Now, here's another thing. We're going to change courses for a minute, and we're going to look at stuff outside of medicine. Once again, does anybody know who this guy is? No hands. If you were to make a catalog of the heroes of World War II, the people in America that helped us win the war against tyranny across the globe, this guy's probably not on any of those lists, but he should be at the top. Okay? This guy is W. Edwards Deming. If you do any learning in quality improvement, this guy's name comes up over and over and over. This is really the guy that made a lot of what we're going to talk about possible by building on what was done before him. He was a physicist and statistician. He is the one that took American World War II production and created the incredible machine that outbuilt the tyrants. So although he's not on the list, although he never fired a weapon in anger, he's the guy in many ways that's responsible for the Allied victory. He was working for MacArthur and was doing census work in post-war Japan when Japan took his production ideas, invited him to become their expert, and he's the guy that created the difference between what I knew as a little boy and what we know today. When you were young, those of you who are not, when you were young and something was made in Japan, what was the quality? Crappy, right? Cheap, junk. Now, made in Japan. Top of the line. Deming. Okay, and he had a number of wonderful ideas. And one of those is the aim defines the process. If you are aware of where you're trying to go and pay attention to the way you get there, you have an understanding of the process. And actually, this is the picture that most people see, but he wasn't born old. So he started out much younger. So he developed the idea of quality improvement, or he expanded the idea of quality improvement, where organizations can increase quality and at the same time reduce costs. That should sound familiar to those of you who work with IHC. And one of those things he developed, expanded the development of, was the statistical process control chart, a visual way of looking at things so that the data can actually make sense and help you to make a difference in what you do. I'll show you one here in just a little while. And so that leads us to the next guy. So who is this guy? All right, just checking to see if you were paying attention. I don't know if George has anything to do with quality improvement, so we'll go to who is this guy. Who is this guy? Brent James. Okay, somebody knows this guy. So he's a lot younger than the other guys. So he was born in the more recent past, and this is his training, rather extensive. If you have the opportunity to spend much time with Dr. James, he really is one of the most brilliant people you will ever run into. Very enjoyable, and this is his current title. So, for our purposes today, he's important because he's one of the authors of these following articles: To Err is Human, and following that, Crossing the Quality Chasm. So To Err is Human came out in 1999. Do you guys remember that? All those who really do remember it coming out, raise your hand. Okay, so this is, for the next century, going to be the equivalent of the Flexner Report. So this landmark study showed that from 50,000 to 100,000 people die in American hospitals each year. Now, when it first came out, and I heard these numbers, I thought that has to be absolute bogus material, right? I mean, there's no way. How many of you have personally killed somebody in the hospital that you didn't intend to? One. Okay. At least we have some honest people. So, and being involved with the residency, I mean, I'm looking at multiple patients all the time. I don't remember the residents killing people. And so, some of them were close, but I don't remember them killing anybody. And so when I took the course with Dr. James and he went through the ways these numbers were actually developed, it is very impressive. And what you really learn is these numbers are too low, not too high. So if we think about it, that Mighty Mouse approach, that ability to stuff as much into our brains as we possibly can and then turning us loose, results in 100,000 deaths per year that shouldn't happen. And if you notice the last sentence there or two, even using the lower estimate, preventable medical errors in hospitals exceed attributable deaths to Rex, breast cancer, and AIDS. Pretty scary. So that was followed just a little while later by Crossing the Quality Chasm. And what this did was give us some ideas on how we can actually make changes, which leads us to, now where do we go? Clinical quality improvement. We're trying to take the best that we have from the last century, from non-medical quality improvement, from this idea of stuffing stuff into us as much as possible and making American medicine way better than it was before and in many ways the best in the world, and saying, where do we go from here? It's supposed to be a method to convert experience into something that we can actually learn from. It provides tools that we can actually use, and it doesn't matter what our specialties or our place in medicine. This isn't restricted to physicians. These are the concerns from the quality, from Crossing the Quality Chasm. Healthcare should be these 6 things, and this is just not controversial. We all would agree with this. It should be safe, effective, patient-centered, and so on, so that we can give our patients the best that American medicine can actually give. So I'm going to share an example of the quality process. And this is an actual example famous in the IHC system. We'll start out again with, who is this guy? Anybody know this guy? Kim Bateman. Okay, so Kim Bateman was a family physician, is a family physician, actually trained in the Ogden program. And he was also part of the IHC administration over rural hospitals. And so he looked at a project where he said, what's happening in our own rural hospitals? And he looked at community-acquired pneumonia. And so his project was to initially get background data. I want you to look for the familiarities here to what we've said before. So he used the rural intermountain hospitals community-acquired pneumonia. The part we're going to focus on is the antibiotic choices, and that's in red. So a number of things you can see. It didn't seem to be a pattern about how stuff was used. And when we get to this bottom, 102 patients, 68 different combinations. There is no way all of those can be best practice, right? But what it does represent is that Mighty Mouse approach, the craft of medicine. The way I pick is the right way. So that's what we've said. The craft of medicine leads to that. So where do we go from here? So the mission was admit the right people. Use the right antibiotics. Now the way we chose the right antibiotics was to do literature search, to find the best evidence available at that time to make the choices. Give those antibiotics as soon as we can. It doesn't make sense to sit in the hospital not getting treatment. And anything that gets in the way of getting that treatment as quick as possible should be set aside for later, if at all. Now, you don't need to read this. You just need to see that it's a flowchart. One of the things that you learn in quality improvement is to use visual tools that help you to see where you're going. This is simply a flowchart to look at the process. There's one of those key words again. The process of getting from where we are, a sick patient, to where we want to be, treating as soon as possible. So these were the goals for the outpatients. Give those right antibiotics and the choices that were done from the beginning. Notice that the hospital-based patients are going to get Rocephin and Azithromax, actually, is what they would give. So these are the antibiotic choices. There they are in red. Some other treatments that we're going to give along the way, and how do we measure this? So this is kind of some of the fun stuff. So initially, 39% of the patients were admitted. After the protocol was started, 29%. The length of stay dropped. The time to antibiotics, which wasn't terrible in the beginning, dropped still further. This is where it starts to get interesting. This is where it really gets interesting to administration. Half the cost. The savings based on 100 cases a year, incredible amounts of money saved. And as you look at quality improvement, there will always be a cost impact. Most of the time, much of the time, that may be beneficial, but sometimes more money has to be spent for higher quality. So when the compliance to the protocol was only about half, it already reduced 30-day mortality by 36, and with the current compliance, it saves about 60 lives a year. So we now have a care process model within IHC. When you took those 102 patients initially, 68 different combinations, all those doctors thought their way was the best. If they didn't think that, they wouldn't have done it that way. Those are cats, right? How do we herd the cats? What we herd them with is data that they can see. And when we see that, here is the SPC chart I told you I'd show you. It shows incredible compliance with that process because it works. And because as the doctors look at it, they can see that it works. It's better for their patients. Now this mark at the end is actually an aberration. That's not correct. And the reason it's not correct is we don't want everybody to get the same thing. If your patient, for appropriate reasons, doesn't fit a protocol, don't use it. It's not to make you stupid. It's not to lock you into something. It's to give you tools to help you make appropriate choices and to vary from the protocol wisely when necessary. So there is something better than the craft. It's not that we don't want the craft. We still want Mighty Mice to come out of the medical schools. We still want them to come out of residencies. But we want them to have more tools. We want to use all the good that comes from the craft of medicine and add to that. So we want to have more tools. We want to have more observations. It can be done in this system process like we have showed here with this one, but it can also be done with individual patients. So in primary care, a lot of what we treat is depression. We use a lot of SSRIs. For those of us that have actually looked at the literature, SSRI is about this much better than nothing. And yet in practical experience, that's not the case. We could build a quality improvement project, and if we looked at that over decades, if I could stand up here and say, instead of in my opinion, I could say in my measured opinion, here's the statistics, and show you the efficacy, I could give you something much more valuable than just saying, gee, I think it works. So that's a brief summary. But wait, there's more. If you buy today, we'll get more here. So here's my agenda. But first, this is a dermatological conference, right? I mean, our wonderful leader, Dave Allen, is a dermatologist, brilliant dermatologist. We love to have him here in the community. And each time the president organizes the Ogden Surgical, it should and does reflect their interests. So, what is this? This is skin, right? So I didn't want to be left out of the derm conference. So this is skin. This is actually my middle daughter's arm, okay? And when she was about 12, she's actually modeling today for those of you who will be going to the ladies' social. But when she was about 12, she was a volunteer for the nature center here in town. And one of the 5-year-olds following behind her said, "Hey, hey!" And she finally turns around and looks at this little kid and he says, "You have spots." So the real question is, what color is her hair? Red. Absolutely. Thank you. So that's my dermatological approach. Now here we are, the doctors of today. Now, if you have seen or are going to see The Avengers, you will notice that even superheroes find it better to band together. And I love the title, Towards Tomorrow. That's where we are right now. So here we go. We're going to invite you today to join the Ogden Surgical Society in this process. Now, last year, the graduates of the residency all had to participate in a CQI project. All those graduates from last year, stand up. Carissa, I see you, so you have to stand up. You may be the only one here. Okay, we got 3 here. Okay, so did you stand up? Did you guys love your CQI project? Liars. Okay, they hated it. Okay, and I take responsibility for why they hated it, right? It was just one more thing they had to do in residency without really giving them the concept that it's a process that can strengthen you in the rest of your medical life. So they participated in this. They were kind of the beta test site. And there's still some things to work out. This is available through Ogden Surgical. You're going to have more and more pressure in the future that your CME credits will have to come with a project. And this is the kind of project that you will want to be involved with. Now, what I can't tell you is how much it's going to cost, because the Ogden Surgical Society hasn't decided how much it's going to cost. If it's free, it will be worth just what you pay for it, kind of like the lecture today, right? So there will be some cost, but I don't know how much it will be. It will be appropriate. And this document, which you will get through the great guiding force of Teresa Puskedra, she's right back there. So you all, if you don't know her yet, you will want to know her through this process. And her name is in your stuff. It's coming up pretty quick right there. So you'll get a hold of her, you'll get a hold of this packet or some iteration thereof, and you can begin to work through it. And it will show you how to start some CQI process. Now, this is still a work in progress. So part of the fun that you'll have is you'll be able to give us feedback. And one of the things that's not required in it at this point, but I think would be valuable, would be to learn how to develop your own SPC charts. which does mean you get to have to learn at least some rudimentary level of Excel, which can be painful. I speak from experience. So it teaches you how to look at what you want to look at. It can be a big thing, the community-acquired pneumonia. It can be how do messages work in your practice. It can be, do SSRIs work? It can be, gee, how long are my patients waiting in the waiting room? Lots of things can actually respond to the process. So we're not going to go through a lot of these except just to say that the whole thing is available to you in your packet, and it will help you to go through the stages of data collection, of doing the background, of taking what your objective is actually going to be, and then actually getting to something that is important, which eventually will be what are the aims of your process. Project AIM. So all of these things will help you to get there. Now, as we talk about this, is this all a new concept? Yes, no? Okay, now I can't see it on my screen. Up there. So I can't see it on my computer here, but there's a little arrow down at the bottom. Can you hit the arrow? That'll skip way ahead. That didn't do it. There should be a way to see that little arrow to the right. It should hit you there. Okay, so these are resources. Thank you. These are resources that I want to share with you. There are clinical quality training programs. I'm going to share with you two, and the third, of course, is the Health Insights form that I've just given you. The first one is the Intermountain program. Intermountain is respected across the nation and internationally for its quality improvement training through Brent James. If you go there, you can actually sign up. There's about a 2-year wait now for the course. There are two versions of the course, the full ATP, which is 20 days out of practice in the training center, or the mini ATP. ATP stands for Advanced Training Program, brilliant acronym. The smaller one is 11 days, sorry. They are well worth the time if your opportunity allows you to do that. If not, then the Institute for Healthcare Improvement is another tremendous site, and that's available online. The cost is very minimal, a couple of $100 a year, and the amount of material available there is incredible, far more than any of us could do if you tried to do all of it. And it is absolutely pertinent and a lot of fun. So a couple of closing remarks. Who is this guy? Nobody. This is Maimonides. Maimonides was born a long time ago. Brilliant guy. Did extensive writing. It turns out he was also an incredible physician. And some of you should be familiar with his oath, right? And so he created an oath. And I want to read the oath. So here's the oath. The eternal providence has appointed me to watch over the life and health of thy creatures. May the love for my art actuate me at all times. May neither avarice nor miserliness, nor thirst for glory or for a great reputation engage my mind. For the enemies of truth and philanthropy could easily deceive me and make me forgetful of my lofty aim of doing good to thy children. May I never see in the patient anything but a fellow creature in pain. It's this next slide that's the cool part. Grant me the strength, time, and opportunity always to correct what I have acquired, always to extend its domain, for knowledge is immense, and the spirit of man can extend indefinitely to enrich itself daily with new requirements. Today, he can discover his errors of yesterday, and tomorrow he can obtain a new light on what he thinks himself sure of today. O God, thou hast appointed me to watch over the life and death of thy creatures. Here am I, ready for my vocation, and now I turn unto my calling. Thank you. It's not really the type of presentation that engenders questions, but if there are any. Sir. Well, now that's an excellent question, Ralph. How is it going to affect retirees? I suppose it will affect retirees because as you end up in the medical field as the patient, we will have better opportunities to practice excellent care on you and not kill you in the hospital.
Please go to the mic for the questions. And the Health Insight is here. The Health Insight representatives with the packets. So if you do want any packets, they have a booth down by the elevator.
And I did forget to mention, Health Insights is the CMS quality improvement organization for Utah, and they are partnering wonderfully with Ogden Surgical, and we appreciate their help and support. Thank you.